All right, so we're going to get started. I think people will continue to trickle in here, as is often the case. So I have the honor of introducing someone that we all know pretty darn well, Zach Bloomgarden, who is going to be giving, I'm sure, a very elucidating talk on Beyond A1c. I'm excited to hear about it. So everyone knows Zach, so I'm going to give sort of a few lines here as an introduction. And I was intrigued to sort of see your background here of where you trained. Princeton with a senior thesis in mathematics that was 45 pages, and then Zach was at Einstein for his med school. He then did an internship at Montecure, so it sounds like you stayed there for a period of time, and then ventured out to Vanderbilt for his fellowship, and then brought you back to New York. And you've been one of those tried and true people who's been at Sonic from the beginning. Which, you know, for all of your professional career. And as everyone knows, Zach has had a very prolific career from not only a clinical perspective, but as well from a publication and interest perspective. He has been the lead on the head of the Journal of Diabetes for many years, which has gone on with Impact Scores, which matters. Over time, and it's been very impressive, and we've submitted a couple of articles for which you've given us some nice feedback on, and always has something incredibly erudite to say about various areas of diabetes, and we look forward to your talk today.
Well, thanks, Carol. So this is actually, my computer died, and I thought I was going to copy the file from my laptop, and so I was able to, I realized that I just gave the talk in Shanghai a couple of weeks ago, and actually a week and a half ago. So I was able to find my email and send it, so it was here. So this is kind of an extension of what Earl Hirsch talked about 2 or 3 weeks ago, that A1c is an extraordinarily useful test that we all love, but there's a lot to it. And so we'll talk about another area a little bit past. First, we'll go over a little bit of what Earl talked about. So here's my multiplicities of interest. So we'll talk about different approaches to quantitating glycemic exposure, what A1c might mean, but then I'm going to spend most of the time talking about glycemic variability and what that means, and what it means with A1c variability, glucose variability, and so on. So glycemia is clearly related to outcome, and there are 4 million studies that show it, and here's one that was just published in Diabetes Care with about 300,000 person-years of follow-up looking at fasting blood glucose and hemoglobin A1c, and showing that both in women and in men, cardiovascular outcomes increase in individuals either with higher fasting glucose and higher A1c. Interestingly, in this analysis, they also published just fasting glucose versus outcome, showing the same trend. So right, so here the previous one was fasting glucose, and here's fasting glucose and A1c. So how do we quantitate the exposure of a given individual to glucose? That's the crucial question. And I've thought for a long time that A1c is often misleading. I see patients that get an A1c, and I say, this just doesn't exactly make sense. And so about 10 years ago now, Derek and Sylvia Rizuki and Ellie Gabrielli, who was here visiting from Israel, and I wrote this kind of comment piece in Diabetologia. And around that time, I wrote an article with Eric Kilpatrick and Paul Zimin on the same topic, and I had a piece in Diabetes Care on it, and particularly it annoys me that people use A1c so cavalierly for diagnosis of diabetes. And so Dan Einhorn and I wrote an editorial in Endocrinology Practice on the topic, because the data is just not that good. So this is a review that Emily Gallagher and Derek and I wrote in the first issue of Endocrinology Diabetes. And this figure that Emily did totally, I had no input on, is kind of sums it all up. That there are, on the top here, you see glycation of hemoglobin. And so that's the piece that, whatever the prevailing glucose level is, it attaches to the hemoglobin at the N-terminal value, and that is proportional to the blood sugar level. Although it also is affected by intraerythrocyte pH, and then there's actually deglycation, which occurs in the erythrocyte. And all of these probably have genetic controls, a variety of factors, and then there's red cell turnover. So with greater erythropoiesis or with greater erythrocyte destruction, you'll see completely different levels of A1c. Here's a study I did with some people from Eli Lilly, where we took individual patient data from a number of trials of insulin titration, where we had 3 days of 7-point glucose profiles and A1c levels. And what this figure shows is that at each A1c grouping, so greater than 9.5, 8.5 to 9.5, 7.5 to 8.5, and so on, if you then kind of do a frequency histogram and then add it all up, you'll see that about 10 or 15%, whatever curve you're on, are well below. So here's the average. So indeed, if your A1c is 7.5 to 8.5, your A1c, your mean plasma glucose is about 8 millimoles per liter. So sort of, that's this APAG concept, A1c derived average glucose. But there are plenty of people on the lower end of their actual mean glucose. And there are a lot of people who have a mean glucose and whose A1c is way better than they deserve, essentially, if you will. So this is part of the issue. Here's a nice analysis that came out from a study where continuous glucose monitoring was done, and in individuals not having diabetes or people with early type 2 and rather low A1c, or people with type 2 and A1c over 6.5, there's a fairly substantial proportion of the A1c that's explained by non-glycemic factors, particularly though in people who don't have diabetes. And so if you don't have diabetes and you happen to be a high glycator, you may look like you're in the pre-diabetes or even the diabetes range, and it's not true. This is particularly important because this study was done in order to quantitate the relationship between A1c and mean glycemia on CGM, and so they excluded everyone with kidney disease, everyone with anemia, everyone who had anything wrong with them. And so in a real population that we take care of, A1c is not particularly a great test. So here's a wonderful article that just came out of JCENM, and Robert Cohen has been involved in this whole question of what to do, why do A1c and glucose not always match for a long time. And so I love this thing, and I'm just going to read part of it to you. So the emphasis was not on those individuals whose discrepancies were because of hemoglobinopathy. Okay, that everybody knows. You have sickle cell disease, A1c is lower, etc. But rather those with normal hematology whose A1c and glucose miss each other by just enough not to make sense. Exactly what we see as clinicians. This is before continuous glucose monitoring, etc. So he said, when asking fellow clinicians, there are generally two responses. A, I see at least one person a week with this issue, but I don't have time to think about it. Which is what a lot of people would say. Or, I thought it came from patients not reporting their finger sticks properly, or the A1c assays were variable. But actually, there are studies going way back which show that A1c is sometimes higher, high glycators, and sometimes lower, low glycators than one would expect based on glucose tolerance tests or other measures. So, for example, African Americans happen to have higher glycation than non-Hispanic whites. So here's a study that looks at the association of A1c with glucose in the diabetes prevention program in non-Hispanic whites and African Americans. And these, basically, everyone was enrolled with a certain high level of prediabetes. So we know they're all about the same. And their fasting glucose levels were 107 and 108, 2-hour blood sugars 165, 164, but A1c 5.8 versus 6.2. So a 0.4% difference, which is quite a big difference. So all the way on the right is A1c versus, continuous glucose monitoring, mean glucose versus fructosamine. In the middle is CGM average versus glycated albumin. And African Americans, non-Hispanic whites, are on exactly the same line, no significant difference. But on the left is A1c versus CGM mean, and the lines are significantly different. So it really matters. So that's one part of this, but the other part of this talk is glycemic variability. So as you think about it and worry about it, we as clinicians constantly are faced by people whose blood sugar is higher and lower. So here's an old article in one of the first issues of Diabetes Care by John Service, who was a famous person at Mayo Clinic way back when. And he said, here's an unstable diabetic, here's a stable diabetic, here's a normal person. Look at the tremendous variability in blood sugar. So it's not like we just discovered it today. Then he proposed a variety of different measures: mean glucose, mean amplitude of glycemic excursions, MAGE, something called an M value, mean of daily differences. And a lot of these have continued over and are present on the CGM analyses that we get either from Dexcom or from Abbott. Um, so these actually have important differences. And this is an interesting study which took a look at individuals with type 2 on multiple daily insulin injections and said, what about the coefficient of variability of continuous glucose monitoring, and what does that relate to? So here, as the CV of the glucose goes up, these are people with type 2 diabetes, so there's a big range of C-peptide, and those who have more endogenous insulin have less glycemic variability, those who have less have more glycemic variability. And that's clinically quite important because it translates into differences in frequency of hypoglycemia in a very major way. So we know about that. Are there other things that the variability of glucose is associated with? So this is kind of an interesting, important study that was published in Diabetes Care within the past few months. This took 300 individuals who were hospitalized with MI and put on an insulin drip. They were, moderately sick, but they said, what are some of the factors that were associated with subsequent complications of recurrent MI or stroke or cardiovascular death? So prior coronary disease, smoking, cholesterol, LDL, left main, triple vet, a million factors in univariate analysis. But in multivariate analysis, history of prior coronary artery disease, the syntax score, which is something derived from how bad the coronary angiogram is, left ventricular ejection fraction less than 40%, and they took all of the blood sugars that were done during the 4 to 10 days in hospital. They looked at the glycemic variability of those blood sugars. So this is data that we have in every hospitalized patient who gets finger sticks. And if the glycemic variability, however they measured it, was greater than 2.7 millimoles per liter, that those people were at higher risk of MAGE. So look at that, all this complicated cardiovascular stuff, and then our blood sugars. And it also tracked with simply having a higher admission blood sugar, higher mean glucose, or with development of hypoglycemia. So a lot of glycemic factors in people with diabetes are extremely important for cardiovascular outcomes. Here's another very similar study. 200 people post-MI on IV insulin for hypoglycemia. And if you look at this syntax score tertile, those who were in the worst syntax score tertile had the highest MAGE. That's this John Service measure of mean amplitude of glycemic variability. And what was associated with high glycemic variability? Sex, syntax score, A1c, blood sugar, duration of diabetes, insulin therapy. So a lot of the things that we worry about, but there's this issue that cardiologists say, well, the blood sugar, okay, you take care of that. We're going to just worry about putting the stent in. It's not so simple in patients with diabetes. Continuous glucose, a little bit of a digression. CGM is modestly effective in lowering A1c in type 1 diabetes and in type 2 diabetes. So we certainly are increasingly deciding this is a test that we need to do in a lot of our patients. And one of the things that we can get from CGM is these measures of glycemic variability. So this is a graph that looks pretty much like that John Service graph, but this is from a much more recent article by Guillermo Pierres, who was here a few months ago. And so you take the glycemic variability in a given individual, here's over a 72-hour period, and you can get time in range, you can get the amplitude of the glycemic variability. A lot of factors can be calculated, which are very useful in addition to just looking at the mean glucose. So here's from Robert Fugierski, who said, look, the time in range, which is just another way of looking at glycemic variability, is a very easy way of expressing this notion of that the mean blood sugar or the A1c are not everything. So he has three different curves. Here's a patient who stays 100% within the 70 to 180 range. Here is a person who's up and down and up and down. Here's someone who's got less variability. And the point of this graph is that if you average these curves, they all have a mean glucose of 154, yet we know they're not the same person. We have all these measures of glycemic variability, standard deviation of the mean glucose, the coefficient of variation of glucose, age, et cetera, and then we're going to talk about visit-to-visit changes, because there's also long-term glycemic variability, which is quite important. So this is kind of similar to what we talked about before, glycemic variability as another important factor beyond mean glucose. So here's mean glucose, 200 people with type 2 diabetes, this is from Monnier, and an older study looked at individuals with type 2 diabetes, no symptoms of hypoglycemia, and the question was asked, when you do, I think this was a 3-day CGM, and you want to see how many people, or 48 hours, how many hypoglycemic events did people have in various groupings. Those who had the lower mean glucose and the greater degree of glycemic variability, here measured by the standard deviation of blood sugar, actually had the highest number of hypoglycemic events, which makes perfectly good sense. With A1c, it's actually a little different, that if you look at hemoglobin A1c versus hypoglycemia, and you look at the standard deviation, those individuals with high standard deviation of blood sugar have more hypoglycemia, and those who have low A1c have a higher level of hypoglycemia, but also people who have high A1c have more hypoglycemia. This is kind of a factor that's very important in interpreting the Accord study, where we rush to the notion that low A1c is associated with adverse outcome. Maybe lowering the A1c overly is an issue, but actually it's probably more that in individuals with poor glycemic control, where you make an extremely, essentially a futile effort to lower the blood sugars, you're then going to cause hypoglycemia without necessarily improving overall glycemia. So here's another analysis of the same thing, and I'm just showing you the number of studies of this topic is immense. So here's hypoglycemia versus glycemic variability, looking at mean glucose and standard deviation of glucose. If both are abnormal, that's when you have the most hypoglycemia. The other point, though, is that if you want to say, well, what about other complications? It turns out that glycemic variability is strongly associated not just with hypoglycemia, but with a lot of bad things. So there's a literature that we're going to explore a little bit on atherosclerotic cardiovascular disease versus glycemic variability. But certainly hypoglycemia tracks with ASCVD, whether you look at individuals who have a history of macrovascular disease, or if you simply look at the carotid intima-medial thickness, you can find that there's a strong relationship between these. Continuous glucose monitoring tracks with neuropathy. So what are the factors that are important? Well, here's an analysis of MAGE versus diabetic peripheral neuropathy, showing that the area under the curve is 0.75, so pretty sturdy as a marker of glycemic variability, then being a predictor of diabetic neuropathy. Autonomic neuropathy, much the same findings. So if you look at the standard deviation of blood sugar or MAGE, or the coefficient of variation, the standard deviation divided by the mean, you find that there are significant relationships between many of these parameters and autonomic dysfunction. But here, they went a step beyond that and they said, well, if you look carefully and do multivariate analysis, where you look at how do all these factors work together? In multivariate analysis, short-term measures of glycemic variability are not as strongly associated as long-term measures of glycemic variability. Essentially, the variability of A1c is really important. So if a patient comes to you and their A1c is 7 1 month and 9.3 the next month, or 3 months later, or whatever, those individuals who are better and worse and better and worse seem particularly at risk. So if we go through these measures of glycemic variability, this last one, visit-to-visit changes, may be something that we look at as clinicians. We look and we see, well, now it's better, but before it was worse, and now it becomes worse again. But this is going to be very important. So let's look at the data on A1c variability. First of all, what does it represent? So here's a very interesting study from one of the managed care journals, which looked at A1c variability quartiles, or it looks like quintiles actually, and then the likelihood of non-adherence. So it appears that those individuals in the highest quintile of A1c variability also were 3.5 times more likely to be non-adherent. There's a variety of ways of defining that. Makes perfectly good sense clinically, but this suggests that there may be a really important explanation. So here's another study, individuals with type 2 diabetes, looking at A1c standard deviation tertile, for the highest versus the lowest. So they look at age, sex, duration of diabetes, diet, insulin therapy, lipids. Well, a number of factors appear relevant, but very interestingly, if you look at social class distribution, which we know tracks among many other medical parameters with ability to follow a medical regimen, we see that there's really a shift in distribution. So those with lower A1c standard deviations seem to be relatively evenly distributed across all the social classes, whereas those with high A1c variability have a higher percentage in the lower social classes, lower percentage in the higher social classes. So this may be a very important factor, and maybe it's not, it is a glycemic variable or measurement, but perhaps it's one that tells us something about the individual in a very important way. So what does A1c standard deviation track with? So here's a meta-analysis in type 1 diabetes, risk of diabetic nephropathy, risk of cardiovascular events, risk of microalbuminuria, risk of retinopathy. Pretty much everything that goes wrong tracks with the variability of A1c. The same meta-analysis a few years ago, looking at a variety of studies in type 2, A1c variability tracking with nephropathy, with albuminuria, with macroalbuminuria, with foot ulceration, and very ominously with mortality, both short-term and longer-term follow-up. Adolescents with type 1 diabetes, relationship between A1c variability quartiles and albuminuria, retinopathy, cardiac autonomic neuropathy. So again, those individuals who are unable to maintain a steady, even level of control seem in another fashion to have a worse outcome. Here's an analysis that Eric Kilpatrick did that was, again, done about 10 years ago at the time that he and I wrote that article in BMJ. So they took data from the DCCT and they looked at the A1c percentile adjusted for the standard deviation of the A1c and showed that the A1c percentile adjusted for standard deviation didn't seem to explain retinopathy in the DCCT, as well as the standard deviation of A1c adjusted for the mean A1c, suggesting that this is a kind of underappreciated, very important element in what goes wrong in diabetes. So another article, A1c standard deviation and versus nuance at microalbuminuria, meta-analysis in type 1 and type 2 diabetes. So they use the Kilpatrick study and a variety of others. A pretty strong relationship. Neuropathy prediction. These are receiver operating curves, and the solid line is the coefficient of variation of the A1c. The dotted line underneath it is the mean A1c. So the area under the curve, the A1c coefficient of variation, is clearly greater than that for the mean A1c as a predictor of neuropathy. And here's a Taiwan study looking at diabetic peripheral neuropathy. And again, if you look at but here they looked at the fasting glucose coefficient of variation, same sort of data. This is fascinatingly study that showed that COPD tracks with glycemic variability in a population, or at least respiratory symptoms. Another one on the same topic. So this is really an important clinical marker, and it's interesting because this is data that's available to all of us, great for clinical research, and it's just beginning to be appreciated. So here's an article, another study of atherosclerotic vascular disease, relationship to glycemic variability. And so the A1c standard deviation corrected for everything is at least as important as age and duration of diabetes, LDL levels. So really a major way of looking at an individual and saying, what is this person's risk of atherosclerotic events? Here, atrial fibrillation development versus lower or higher standard deviation of A1c. Mortality, same analysis, lower or higher standard deviation of A1c tracks with survival. Here's an Italian study, same findings, again, the same sort of multivariate analysis, but here they looked at the mean A1c or the standard deviation of A1c, and they again found that the standard deviation of A1c appeared to be more significant. Here is survival curves, and I forget exactly what the 4 lines represent, but essentially it's the higher versus lower standard deviation of A1c, showing that if you divide the population appropriately, you'll show that those individuals with greater glycemic variability have worse survival. Another study on mortality, here it's expressed a little differently. So the hazard ratio of mortality increases as the standard deviation of the A1c goes up. Another one looking at the coefficient of variation of fasting glucose. You don't actually need A1c to do this. And so, what about in individuals who don't have diabetes? So this is the ALL-HAP study, which was a study, a hypertension study. And the question that was asked here is the fasting glucose as a categorical variable versus mortality. And they were able to show that in multivariate analysis, the variability of fasting glucose in this non-diabetic population tracked with adverse outcome, and those in the 2 lowest quartiles of variability had about half the mortality rate of those in the 2 higher quartiles. So this has also been meta-analyzed, and fasting glucose variability is a similar risk factor to A1c variability. So here's a population of individuals who did not have diabetes, didn't have comorbidities, and the question was simply asked among people with hypertension or non-hypertensives, among females or males, what is the 5-year likelihood of atherosclerotic events versus the A1c standard deviation? So what does this mean? That there are, if you, leaving aside what are the numbers in the boxes represent, it's just that as A1c variability goes up, there's higher likelihood of MACE. This one, let's skip over. So a final question is it just glycemic variability that we should look at? So here's a study from a Korean national health insurance system. So Korea has a rather remarkable way of tracking all of its population in terms of medical outcomes. And they've contributed a lot of very interesting epidemiologic studies. So here they put together a measure of variability of cholesterol, blood pressure, fasting glucose, a variety of factors, and they created a variability score. And they found that variability score of all these factors tracked with mortality, tracked with MI, tracked with stroke. So it may well be that this is not exactly a diabetes test, but it's really a test of adherence or of overall ability of an individual to follow a medical regimen. That's the story. That there's a lot to look at here, and we should be very careful in analyzing A1c levels, in looking at continuous glucose monitoring, but we should also go beyond that and think of what data can we get from this, and how can we then use it to better take care of our patients. So this is, most of the references for this are in the commentary that is in press in the Journal of Diabetes, and I don't know if it's quite online yet, but it will be out soon. So thank you all.
That was great. A couple of questions. One is, talk about people who are high glycators. I forgot what the word is. People who just maybe glycosmic, whatever the actual verb is. I always thought that was part. It was felt to be causal in some of the complications. So Brownlee's work on glycosylated collagen. So has anybody looked to see if you're like a high glycator, does that correlate with diabetic complications?
There is a literature looking at the A1c fructosamine ratio as a possible measure of glycation, but I think it's pretty soft. But it may indeed be that that's another part of the story. But if you compare 40-year-olds versus 70-year-olds, 70-year-olds are higher glycators than 40-year-olds. And so it's utterly crazy that we take older people, measure A1c, and we say to them, your A1c is 5.9. You might be pre-diabetic. And then if you do a glucose tolerance test, you're fine. No.
That would be why Medicare no longer pays for that test, unless you code it in a very special way. And one other thought, not to bring this into the adrenal realm, but some of those people who are very variable, could that have something to do with some other hormones, like their catecholamines, their cortisol levels, their...
So it's the best explanation of glycemic variability seems to be endogenous insulin. So could it be that counter-regulatory hormones play a role, people with high catecholamines, people who have high glucagon or low glucagon? You can equally argue that people who are less able to have a counter-regulatory response are going to have greater variability. And certainly we think that in type 1, both catecholamines hypoglycemia unawareness, but some of the same entity. So the answer is there's a lot of factors. Yeah.
The previous discussion brings the question of the label prediabetes. So if you're basing prediabetes on glycation of hemoglobin, you're going to be mislabeling a lot of people. And from what I can see, there's nothing that the A1c between 5.7 and 6.4 predicts that's any better predicting diabetes than family history and all the other factors that we know are factors in development of diabetes. So I wonder whether we should throw out that term prediabetes based on A1c.
Well, I sort of agree, but epidemiologically, A1c is quite a good way of predicting who's going to develop diabetes. If you take a population and you look at those with an A1c of 5.7, 5.9, 6.1, 6.3, you'll certainly see that more of those with higher A1c will go on to develop diabetes. So it's not that it's worthless, it's just that the positive and negative predictive values of A1c are undesirably low, or I guess high or low in the wrong direction. So I certainly like doing A1cs, but it is utterly frustrating to see that, people with renal disease, the nephrologists love to do A1cs. All of their diabetic patients are so well controlled. Somebody just came to me yesterday with a young man in his 40s with about 8 insensitive feet, so he's on his way to disaster. His A1c and blood sugars seem utterly discrepant. So his primary care doctor put him on metformin and then on glycyrrhizide, our most unfavorite drugs. His A1c came down. He's never had a blood sugar on all these 6 lab tests that he brought in below 200. And so it's a test, but it's not a great test. Yeah.
Thanks. So I find the variation of A1c really interesting, but I wonder if it is also just a biomarker of so many other aspects of diabetes. So in many of the studies, are they taking sort of all the patient's historical A1c data that's available, or are they taking a snapshot from time, saying 5 years of your last A1cs? I think that some of the models control for number of A1c tests, or they account for it. But is that sort of the standard in a lot of these analyses?
So there's no standard. Most of them just essentially take a population that's had A1c tests and then look at the variability of those tests that were done. The more control you have over it, the better. But outside of an RCT, it's going to be very difficult to get a population and get quarterly A1cs on every member and then look at its relationship to outcome.
It seems like the variability explained by the hypoglycemia. I think that we should think through not just variability, but the hypoglycemic part of the variability. Did I hear that correct? Because that would explain a lot of the increase in cardiovascular, if that were true.
So those are short-term studies, and in that analysis, they found that hypoglycemia and hyperglycemia and variability of glycemia all track with age. So is it just hypoglycemia, or is it hyper, or so all of these are tracked with one another. I mean, that's part of the problem, that those individuals with more hypoglycemia in an ICU setting also have more hyperglycemia and also have greater variability based on how one calculates variability.
It just seems like the odds ratio increased as you went from total variability to hyperglycemic variability to hypoglycemic variability. So that's, it was just the difference in those. They were all significant.
Yeah, I don't think we can know, since they're not really separable. I think I would say that's certainly possible that it's hypoglycemia that tracks with events or variability.
Last week, there was a speaker, Dr. Flores, who gave us a different clusters for the different kinds of diabetes. And he actually also said that these are the genetic problems, or these are the genes that are involved. So would it be possible to sort of like, with all those 5 cores of diabetes and the genetics that they have wrong, check down the A1c variability is one of the research protocol that we can do?
Sure. Good idea. Another study.
Yeah.
So, thank you.